I'm going to talk a bit about shoulder impingement. So I'm sure as manual therapists, many of us are used to the common presentation for this in patients. Generally speaking, the underlying cause could be something to do with protracted scapula or internally rotated arms. And there are plenty of good things that we can do for those in clinic as manual therapists. But what's actually really important for longevity and long-term success of treatment in those cases is the rehabilitation aspect. So some of the tests that are less commonly performed are strength tests. And there are two muscle groups that I really want to zoom in on when it comes to those. And that's the rotator cuff and serratus anterior. So the rotator cuff, it's important because it stabilizes that head of the humerus in the glenoid cavity, and ultimately it's like reins on a horse's head, and it serves to control the position of that humerus. So if those internal rotators are winning the battle, then it's going to put the humerus in a bad position, and any abduction, any horizontal adduction is going to cause usually the supraspinatus to rub underneath the acromion. The other group is, or muscle, is serratus anterior. And so why is serratus anterior important? Well, it's often overlooked, but it's very, very important. It serves as the foundation for scapular stability. It's an antagonist to the commonly tight pec minor through protraction, and the upper trapezius is often overworked through scapular depression. So the reason that it's so important, like I said, it provides us that foundation, that solid base for any kind of pressing movement. So this is particularly important when it comes to anyone that goes to the gym, anyone that trains with weights. There's a good test that I like to use, and it's actually the same as the exercise that I'll prescribe for the client, which is a scapular press. So scapular press, what we're looking for is adequate retraction and protraction of the scapula with the shoulder girdle staying depressed. It's a common fault in the patient to elevate the shoulders as they try and work out how on earth to protract the scapula while the shoulder girdle is maintained in depression. So the assessment, get the client to stand facing the wall, hands up to the wall, hands shoulder height. Make sure there's a bit of a bend in the elbow, but that bend should stay as it is. We don't want that to increase or decrease. We don't want any flexion, extension of the elbow. Get them to have the shoulders nice and low, squeeze the shoulder blades together into retraction, and that serves as a great jumping off point for them to push the wall away, is the cue that I like to use, into protraction. Most patients won't know how to do this, and so reinforcing those verbal cues, including tactile cues of just pushing down on the shoulders, putting your fingers in between their shoulder blades to feel the rhomboids contract as they go into retraction, and then to give them some passive help into protraction is also quite helpful, I found. So I hope that helps. I'd love to know any thoughts on this, any success stories, and one last thing, make sure that you yourself, the practitioner, can do a scapular press, because you will need to demonstrate and they need to know what it looks like. And I'd love to know how you get on with that. So feel free to get in touch. You can always like and subscribe, helps me, helps the channel. Bye for now.